Good afternoon. I'm Dr. David Walensky, and with me is Dr. Larry Phillips and Dr. Andrea Medina, and we're here to talk today about the appropriate use of myocardial perfusion imaging in women with suspected coronary artery disease. Andrea, thanks for being here with me.
Absolutely.
Tell me a little bit about your approach to the woman who presents with stable chest pain to your office. When are you comfortable making the initial decision analysis of what needs to be done? When do you decide to refer the patient out directly?
So I think the first thing that I do is what you've just alluded to, is make sure this is stable chest pain, first and foremost. And then in that woman, I really look at her history, I look at her risk factors, the type of chest pain, the quality, is it typical or atypical? And in general, I think myself and other internists are fairly comfortable managing these patients at the beginning. Where I would ask for cardiology input is if I'm unsure what test to order or the parameters by which I need to order it. Should it be an exercise or pharmacologic imaging test? Should I just do an exercise treadmill test? I think it might be in that patient who is in that low to intermediate risk category where I'm really not sure whether to move forward with imaging or just do a treadmill test.
So Larry, in the last decade or two, we've seen an increase in utilization of imaging stress tests, but I think there's a lot of data on the role of a simple exercise stress test.
Sure. I think a lot of people should be starting with a non-imaging treadmill test because there are two components that you want to make sure fits the individual patient. The first is that they have an EKG that's interpretable, so that they don't have ST segment deviation greater than 1 millimeter, either from repolarization or left ventricular hypertrophy with repolarization, or the other group being patients with baseline conduction disease, so the left bundle branch block or paced rhythm for that reason. Those are both going to be groups of patients where you can't interpret the EKG and want to instead add imaging component to it. Other EKG abnormalities that are falsely thought to be uninterpretable would be a right bundle branch block or WPW pattern. Those are two where you're able to still interpret the EKG for ischemia. Now, the second thing that you want to make sure when doing an exercise treadmill test is that you're able to exercise sufficiently to get good results. And so what we like to do is use questionnaires that will allow you to determine before the test is even performed that the patient will be able to participate in the program. That can be just making sure that their functional status is high enough. But the other thing is, especially when we're talking about older patients who might not have ever used a treadmill before, making sure that they have comfort in getting on the treadmill, showing them how to use it. And once you put all of those together, you can get a nice test that gives you excellent information about the patient's risk of having obstructive disease.
So Andrea, when you talk to your patients, how do you get a sense of what their physical capacity is and what kind of things bring out symptoms in them?
So I always want to know, I talk to them about their day-to-day activities. What do they do on a day-to-day basis? Are they getting around the house? Do they have stairs in the house? Are they going to the gym at all? Are they carrying their groceries? You know, the things that we think of when we're assessing METs, really. I ask, you know, if they're going to the gym and they're on the treadmill for 30 minutes a day and they're not having any symptoms, but maybe they're feeling a little wheezy when they're walking outside, you know, down the block and it's cold, that helps obviously, you know, differentiate that cardiac dyspnea from just what might be, you know, asthma or cold-induced asthma, something like that. So, you know, really for me, understanding their day-to-day activities and then specifically getting the idea of what brings on the chest pain.
So, you know, the other thing is that when assessing the physical symptoms that people are having in their activity, really using structured questionnaires. So there's one called the DAISY score, which is the Duke Activity Status Index. It's a series of 12 questions where patients are able to, by answering yes or no questions, be able to allow the clinician to come up with a weighted score to predict before even starting a stress test what their functional capacity will be. And as long as we're seeing that they have adequate functional capacity, it helps us in going the next step to doing the test using a treadmill.
And of course, the other thing I like to know whenever I'm talking to a patient is any other associated symptoms. So if they don't really have like classic typical angina pain, you know, they might have some other atypical symptoms or symptoms that are more typical for women, like reflux symptoms or dyspepsia or back or jaw pain. And I think those can be really helpful in forming our pretest analysis and likelihood for the patient.
So you use, for instance, you use the Diamond and Forrester evaluation when you assess people?
Yes. Yeah, so the chart from that table from Diamond and Forrester is incredibly helpful, whether or not you have it memorized or just at your fingertips. Being able to think about the patient based on gender, age, and then the type of symptoms, if these are typical, atypical, or non-cardiac, non-angina type symptoms, is really helpful in determining that pretest likelihood and then moving forward with choosing the right test.
I find it very helpful. I don't know about you, Larry, just to explain to people why I'm choosing a test or not choosing a test, if I can give them something objective that I've used to make a decision with to help them understand why they need to have an advanced test or not such an advanced test.
I agree completely. I think patients often will come with a preconceived notion of the test that they have to have. Either what I sometimes call cocktail party medicine, where their friend has a test, therefore they need a similar test. But that conversation with a patient, to know the question that's being asked, to know their risk for the disease process, and to pick the appropriate test for them as an individual is key. And I think all of the initiatives that we're taking for choosing or referring wisely, for using the appropriate use criteria in the best way it can be used, is all to go back to that relationship that we as clinicians have with our patients, to make sure we're choosing the right test for the right patient at the right time.
I think what's important is to understand pretest likelihood of disease and risk of disease. When we use Diamond and Forrester, we determine what the likelihood of disease is, but it doesn't tell us how bad their disease is. That's where things like the multimodality appropriate use criterion are so helpful. Once you've determined a patient has low risk, intermediate, or high risk, then you pick the best test to risk stratify them. We've all seen low risk patients who have bad coronary disease and high risk patients with calcium score of 2,000 and 3,000 who have no ischemia or no significant blockages. So it's important for everybody, and I think the primary care physicians, to understand the difference between pretest likelihood of disease and the severity of disease. One helps us make a diagnosis, one helps us to determine risk and what further treatment needs to be done.
Absolutely.
And the multimodality AUC are really helpful because it reminds all clinicians, no matter what specialty that they're in, all the tools that you have in your toolbox. It lays out the different testing modalities for the same indication to tell you where in the spectrum that test falls. If it's appropriate based on expert consensus, or is it rarely appropriate based on expert consensus? How do we determine the test for the patient when we know what's available, what we know what's helpful, and then the patient being a participant too in helping decide the right approach for them at that time?
So once you've seen a patient who you decide needs to have an imaging stress test, be it stress nuclear, stress echo, or CTA, or anything else, how do you, as an internist, and how do your colleagues decide which test to order? Or is it time to say, maybe I'm not sure, I'll call a cardiologist or refer the patient to the cardiologist? What are your patients like?
I think my patients, whenever I can explain it to them and they can understand, really do trust the decision that I make. And I can't speak for everybody in internal medicine, but I think, if we can develop and foster those relationships and speak with the expertise and with the evidence, using appropriate use criteria, using guidelines to really explain to the patient and then help that patient understand why we're choosing a test, I rarely feel the need to refer out to cardiology just for the choice of the test. Might I call a cardiologist for a phone a friend curbside? Possibly. But my patients are okay with the initial part of the workup, being decided in our office. Now, often with a positive test result, we'll have to move forward with a referral to cardiology. But and at that point, I think we're both comfortable with that.
And it's interesting that you mentioned that, because the PAMA law that Congress passed in 2014 is going to mandate the use of computer decision support tools with embedded appropriate use criteria. And it's going to be very difficult sometimes for patients and doctors to make a decision together on what they need to have done. What is the best test for them? They're going to have to go check off, does it fit the appropriate use criteria? And if not, there's going to be all sorts of things that will need to be done for the patient to be able to have the tests that they need. So I'm glad the primary care physicians are aware of how important it is for them to manage their patients' care.
You know, whenever I'm making that decision, whenever I'm looking at a test, you know, one of the questions that we have is, you know, how can you know if the patient can exercise? How do you know if the patient would benefit more from a pharmacologic test or a stress test? And how would you all recommend that as internists we evaluate that?
Well, I think a functional assessment in the form of exercise as part of your stress test is always preferred. So to determine if somebody can exercise sufficiently, you want to see that they're able to exert themselves to a high enough level that we're going to get a good test. So using questionnaires such as the Duke Activity Status Index, where the patient's able to fill out questions and see the benefit of exercise is clear. The other part of it, though, is the default, if the patient can exercise, is to go the exercise route over a pharmacologic test, because we're able to get additional functional information. We're able to see their exercise time. We're able to see their heart rate and their blood pressure response. We're able to see how fast their heart recovers after exercise. For patients, though, who are not able to exercise, pharmacologic stress tests give us a tremendous amount of information. And we're able to see, based on relative flow to the heart, how the myocardial blood flow is, and suspicious for obstructive disease in the blood vessels. And it's one of the benefits we have, especially as we see a lot more older patients with a high rate of arthritis, for example, who have orthopedic restrictions to their activity. We're able to get excellent information both for diagnosis and prognosis by doing a pharmacologic stress test.
Do you think the information we get from a pharmacologic perfusion scan is comparable from risk predictor to exercise myocardial perfusion scan?
I think the perfusion imaging that we see is comparable. So I think the perfusion imaging in the nuclear stress test is going to give us size and severity of defects. It's going to give us a cumulative look at the heart, where we're going to be able to see both the presence or absence of obstructive disease, but also be able to have good prognostication. I think the addition of exercise when it's possible does give us additional information as far as their exercise capacity. So that's helpful when we can get it. But knowing that in the United States now 50% of tests are performed using pharmacologic agents rather than exercise for the nuclear stress test. And that's just the nature of the patient populations that we're often stressing.
Thanks for that explanation. So what happens if I order an exercise imaging test and my patient gets there and just can't do the exercise?
So one of the benefits in nuclear stress testing is that you can convert from an exercise to a pharmacologic test. Each lab has their own protocol on how they do it. Some labs will have a direct conversation with the referring physicians, and some have default that they're able to make that transition within the lab. But structurally, at the time of the test, you can make that change from exercise to a pharmacologic agent. And what we do is typically when we try somebody on a treadmill and just realize that they can't do it, it might not even be a functional status issue. It might be that they can't walk on the treadmill, that we're able to make that transition. It adds about 5 minutes to their testing and go forward with, in most cases, a vasodilator test. The good thing is that we're able to continue to do the test the same day, that we're able to get the important information from the perfusion imaging, and we're able to determine prognostic risk based on it.
You know, and I think the patients are very happy that the lab did the due diligence to make sure they got all the information they could for the referring doctor.
Mm-hmm. So what you're saying is if I think my patient can exercise, I should order the exercise imaging. And if they get there and they can't, then most likely the lab will convert that for me or call me and help me make the decision.
Exactly. I think that once that process is started, it's not a tremendous change to modify the approach to the test that's being done. And what you don't want to do is you don't want to do the stress test and have a suboptimal result. Because what we're trying to do is figure out, does the patient have significant obstructive coronary artery disease based on perfusion abnormalities, so reduction in the perfusion area of the heart. So we don't want somebody to walk on the treadmill just for a couple of minutes, not be able to get their heart rate up, and then say, good enough, this is what we have. Instead, we want to make sure that we're in a controlled situation where we can stop and we can convert it to a pharmacologic test and get the information to give back to the referrer so that they have confidence in those results.
So when I get the results back, what are the high risk or the results that might give me high suspicion that I should move forward to angiography?
So I think that's a great question and gets to the crux of why we test people. The reason we test people is to decide whether there's any other therapy that we can put in place that's going to change their prognosis. Certainly you start out with the stress test. If their functional capacity is poor, they had crushing chest pain with serial EKG changes, you don't even need the perfusion images. You know the patient has problems. But one of the advantages of nuclear stress testing is it's very quantitative. And we have a great study, as you can see in this slide, that shows observationally in over 10,000 patients that those people who have an ischemic burden of greater than 10 to 12% do better when they've been managed with revascularization. Those people who have a smaller ischemic burden can be managed medically with a better outcome. So we use that as a very, very good cutoff to decide who really should go to the cardiac catheterization lab. There are other things that we do also. For instance, multi-vessel patterns. Do we see defects in both the left anterior descending artery and the circumflex territory, for instance? Other things is something called transient ischemic dilatation, or TID, and you'll see that score. It means the ventricle or the ventricular cavity gets larger with stress. That's a reflection of decreased blood flow to the subendocardium, and it's a marker of significant coronary disease. Now, many times you'll see reports that patients have, quote, TID of unclear significance. The remainder of the test is normal. Those are less likely to be markers of high-risk disease, and they usually are technical issues. So if you have a lab that gives you a lot of reports like that, you might want to think of using a different lab. And the other thing is the ejection fraction. When we use nuclear stress testing with SPECT, we measure what's called the post-stress ejection fraction. So the ejection fraction, when measured, is usually 10 minutes or more after exercise. So that if you see abnormalities, that reflects stunned myocardium. Now, if you use PET, you can use the ejection fraction that you get at both rest and at peak stress. And a change in ejection fraction at peak stress compared to rest appears to be related to increased risk. So there's a tremendous amount of quantitation that can often make it very clear to decide when somebody needs to go to the cath lab.
So what's the role for cardiac PET imaging?
So cardiac PET imaging offers all the advantages that SPECT imaging does. Good diagnostic and prognostic value, but it has other information that also can be obtained, and it's a better quality test when available. It has better sensitivity and better specificity. There are less false positives, so less people will need to have downstream testing such as coronary angiography. There's better attenuation correction, so there's less likely to be false positives of breast attenuation, which is important when we evaluate women. In addition to the radiation exposure is less, so that's really important when we're dealing with women. In addition to measuring perfusion, we can measure what's called coronary flow reserve, which is a more absolute measurement of blood flow, and it allows us to assess particularly women who may have microvascular disease and endothelial dysfunction. And there's very good data, as you can see on this slide, that even with normal perfusion patterns on PET images, women who have abnormal coronary flow reserve are associated with increased risk.
So do you see PET imaging becoming more used, more utilized in the future?
Well, I think ASNC has recognized the value of it, and as we've gone to a model of volume to value, we need to do the test that's going to give us the most information. That is, if it's abnormal, it's going to lead to further testing and treatment that's going to be helpful. And if it's normal, we want to be comfortable that we can manage the patient conservatively and not put them at increased risk. And I think PET has that great potential.
And I think that's one of the keys when we think about nuclear stress testing as a whole. It's not a test that just is a gatekeeper to another test. It's giving us very important information about the patient, about their myocardial perfusion, and it's helping us make decisions. And the decisions might be everything looks fine, and therefore we don't need to change pharmacologic therapy. It could be that we see abnormalities that we know from research the patient will benefit from pharmacologic changes. Or it might show us that there's a high-risk feature that would benefit from further testing. You know, there are huge areas where we still don't know the answer. In a lot of anatomic tests where we found coronary artery disease, large studies such as COURAGE and Barry 2D did not show benefit of revascularization over optimal medical therapy alone. There is a large study that's currently enrolling called the ischemia trial, which will be looking at patients that on non-invasive testing have moderate or severe ischemia, and then randomizing them to optimal medical therapy alone versus angiography and revascularization with that optimal medical therapy. Medicine is an ever-growing field. And what we found is that with pharmacologic therapy improvements over years, that we don't know the role that revascularization is going to have in some of these patients. And so by continuing to do these tests, gather information, form databases, form registries, we're able to take all of that together to bring it back to the individual patient level and to see what benefits the patient in the long run.
So from a primary care perspective, do your patients understand the difference between diagnosis and risk? Do they understand that just because we put a catheter in somebody and open up a blockage, it may not necessarily make them live better? Is this something we need to really work on from a primary care point of view in order to cut down on some of this imaging because we can?
Yeah, I think you hit a really great point. I don't think a lot of patients understand that. I would venture to say there are probably a lot of physicians who don't really understand that percutaneous intervention with medical therapy isn't really going to prolong the patient's life, maybe just improve the quality of life. So I think we do have some work to do there with making sure that patients and physicians understand that. The patient can really only understand as much as we can explain to them. So yeah, I think that's a great point. I think we do have more room to work there.
So one of the areas where a lot of clinical questions remain is when somebody has symptoms that sound like ischemia, but their tests do not show evidence of ischemia. David, how do you handle patients like that?
So, it's a tough question that's coming up more and more, particularly with some of our high-risk patients, many of whom had objective tests that show no epicardial disease. That's why I don't like to call it coronary disease with women. I call it ischemic heart disease, because if they have typical pain that's brought on by exercise or stress or relieved by rest, that's angina. If they have an abnormal PET scan or an abnormal stress test, that supports the clinical diagnosis. Now, these symptoms may wax and wane for biochemical reasons that we don't know. These patients certainly should be treated aggressively. Aspirin therapy, statin therapy, beta blockers or calcium channel blockers, if they help. These meds may or may not work. But once you've had a clinical diagnosis of angina and a normal coronary angiography, then you don't necessarily need to rush to test these people serially, regardless of what the appropriate use criteria say, that people can be tested after 2 years after a serial 2 years after a prior test.
So Dr. Walensky, when would you retest somebody who had a normal imaging study but still has persistent symptoms?
So I think if the symptoms are stable, you don't need to retest, particularly if you've had a relatively definitive test. If you've had a coronary angiography that shows no significant obstructive disease within the last few years, you don't need to proceed. If there's a sudden change of symptoms, if there are EKG changes, if the pain lasts longer, if the pain is coming on with less activity, and it's been several years since they've had a test, then I would think about repeating a test. Not everybody needs a coronary angiography, but sometimes somebody may have had an abnormal stress test or a mildly abnormal perfusion scan that has not required angiography. But if the symptoms escalate, somewhere along the line you may need to get a definitive coronary angiography or a CT angiography just to rule out significant obstructive disease. If it's a diabetic, if they're active smokers, if their cholesterol has been poorly controlled because they're statin intolerant and things like that. All of these things make me more concerned that they may have developed progressive disease, and what may have just been endothelial dysfunction and small plaque may have turned into obstructive disease.
And I think if you parlay that, and when we talk about treating the individual patient and deciding the right test for the right person, the prior testing that they have plays a role. So if somebody had a nuclear stress test a year before and has not had a change in symptoms, you're hard-pressed to determine that they need to have another nuclear stress test to look at the same thing. But changes in the symptoms, making you think that there's a change in their pathophysiology or change in their individualized obstructive disease, that something could have progressed over that period of time, making them have a change and a result of a further test, that intuitively to me makes sense. And I think in the conversation with the patient, that's what we want to get at. We want to say, what test are we doing? What data do we have, which includes those prior tests? And what information do we hope to ascertain from the test at this point, and seeing if it needs to be repeated or if there's another test that'll get us that information.
The appropriate use criterion describe clinical scenarios where testing may or may not be helpful. We still have to go back down to the individual case. What am I looking for? What do I want to do for these patients? And I think it's very frustrating for the primary care doctors who have all these appropriate use criterion, but only the person sitting across the desk from the patient knows what the patient needs. And I think if you start by thinking about what the patient needs and looking at all the information that you had before, it helps a lot. For instance, we have a lot of smokers who are having screening CAT scans to look for lung cancer. There's a tremendous amount of information that comes in there. You can look at the aorta and see if they have an aneurysm. You can look at the coronaries and see if they're calcified. So take advantage of all the information you can to make a decision on what's best for your patient and what the likelihood of their disease is.
Sure.
And I think it becomes a collaborative relationship. It's the person who's referring the patient for the test, be it a primary care physician, a subspecialist, or anybody else within the medical community, as well as the person who's performing the test if they're different, and making sure that that relationship is strong enough so conversations can occur when there's a question about the modality that you're using, about the approach to the patient, whether it's an exercise or pharmacologic test, what protocols you're going to use. All of these go into place when we're trying to find that right mix and that perfect spot for the individual patient that we're treating.
Sure. So as cardiologists, when you get a call from the internist or from the primary care doctor, what are the things that you want to know? What are the things that we should make sure that we tell you about the patient or about the history so that you can help us order the right test?
So I think clinical stability, as you mentioned early on, are they having chest pain now? Are they having an accelerating pattern? What is their past history in their workup? What does their EKG show? How reliable are they? Are they not going to come for a test? Can they afford to have a test, for instance? Many patients we know have high deductible plans and can't afford expensive tests. Do they need to come to the emergency room? Do they not need to come to the emergency room? And all of these things go into play. You know these patients better than us. Okay, are they under a lot of stress? Are they anemic? Have you checked their bloods? Have you checked their thyroid? How are their risk factors being modified? All those will help. Now, we don't need all that information in order to do a test, but the more information we have, the better we can interpret the test and give you the information you need.
So what can we do as referring physicians to improve our understanding and education about the subject?
Well, I think programs like this, first, where we're able to have a discussion about indications, testing modalities, the approach to the individual patient. What we've also been doing is looking at knowledge base of referring physicians and trying using needs assessments to see what areas we should focus on in our educational activities. And finally, keeping the conversation open and keeping both for populations and different modalities, but also for the individual patient, making sure that we have this free-flowing discussion of ideas and approach, and knowing that the reason we're doing the test is to get specific diagnostic information and what we're going to do with the test afterwards, and making sure that that thought process is taking center stage.
So I think this has been an excellent discussion about shared management for patient care. And with that in mind, ASNC, with the help of the American College of Physicians, has developed what's called the Referring Wisely Initiative. And it's a broad-based clinical education initiative to help people understand not only how to use the appropriate use criterion, but really how to use cardiac imaging in order to best manage their patients with suspected ischemic heart disease. We have a variety of clinical case presentations. We've had papers that are peer reviewed and published in recent internal medicine literature. We have patient care aids such as posters and apps. And this is going to be an ongoing initiative to help referring doctors do the right thing for their patients.
That sounds like great information. Where can I go to find it?
So you can find this at the ASNC website on asnc.org/referwisely.
Thank you. Thank you both for being here and for joining me in this conversation.
Our pleasure.
Thank you.
Thank you.